Our speaker today is, as I mentioned, Dr. George Benjamin. He is the executive director of the American Public Health Association, the most important public health organization in the country. I will note that he is testifying, as soon as he's done with us, he's going to testify to Congress. So I'll just note for the record that we have him first today. So, I don't care what you tell those guys in Congress. We had you first. Dr. Benjamin has experience at the state level as a state health commissioner in Maryland. He's been executive director of the AHPA since 2002. And he is a member of the National Academy of Medicine. He was on a advisory council for President Obama, as well as lots of other items on his resume. We've sent you his full bio, so you have access to that. He is going to talk and present, and then we'll have time for questions. And with that, I'll turn it over to Dr. Benjamin.
Thanks, Chris. Hi, everyone. Let me bring this slide up. And okay. So I'm going to just try to give you a whirlwind, just an overview of where I think we are right now with vaccines. Just to remind you that we've had over 28 million people in our country impacted by COVID and over 500,000 deaths. Just to remind you that we've done this in essentially a year and a month. And these are more deaths than we had in World War II in the whole 6 years of World War II. That the virus is, of course, changing. These viruses change all the time. This is not unusual. But we're now seeing it to be a little bit more infectious, depending on which strain you're looking at. In most cases, most people don't believe it has escaped the vaccine, meaning that the vaccines still work. There are some questions about some of the tests. And I know some of the testing companies are beginning to look at whether or not the vaccine of the virus is escaping some of their tests, meaning that the tests may not be as accurate in some situations. But I do believe at the end of the day, the end is in sight for this epidemic. But we have some things to do to make sure that we actually get there. This young lady, of course, was the first person to get vaccinated in the United States. I'm sure the fact that she was African-American and a nurse at a time when we were trying to get healthcare workers vaccinated was not only an important that she did this, but also a very symbolic picture. To remind you that the vaccines process is one where the reason we take so much care with vaccines is that it's a medication that we fundamentally give to healthy people. And what I mean by that, we're not doing it to treat people's disease. We're doing it to prevent, for sure, people from getting the disease. It may or may not protect people from getting infected by the virus. And studies are ongoing, and we can talk about that a little bit later. But it starts with a few people getting tested to make sure the vaccine is safe. And then they grow that over time till we have over thousands of volunteers. And while it starts with very, very healthy people, they do begin to include people with chronic diseases, diabetes, high blood pressure, heart disease, as part of the cohort of people that get vaccinated. And they also try to make sure that it's demographically representative of the population to the extent that they can. So right now, we've got 2 vaccines that have received FDA Emergency Use Authorization. The EUA process is a process by which we can accelerate the availability of a therapeutic to the population. And it has, in essence, necessarily gone through full FDA licensing. And in most cases, the licensing process is a bureaucratic paper process that takes much longer than EUA approval. But using EUA approval, these vaccines have undergone all of the scientific rigor that you would normally go through for full licensure. And I think that's an important point, that nothing on the science side has been changed. Nothing on the science side has been changed on the bureaucratic part of this in any way. Now, both of these mRNA vaccines are a 2-dose schedule, meaning you have to get 2 shots to be fully vaccinated. And in many ways, the duration of how long you're protected is not known. We don't know that yet. They're getting a sense of it. It's for sure 6 to 9 months, but we just don't know yet. And the reason is we haven't been vaccinating people long enough to know how long it's protected. There's currently the Johnson & Johnson has a version that is undergoing review as we speak today by the Food and Drug Administration. What will happen is a committee of the FDA, which is an independent committee, will of course view that vaccine today. They'll make recommendations over the weekend about whether or not it should undergo approval under emergency use authorization. And then that process goes to the CDC, the Center for Disease Control and Prevention. And then they tell us how to clinically use the vaccine. You know, what age groups is it approved for, whether or not that one dose is appropriate or not. They'll make those final decisions and recommendations to the public as we go forward. And so hopefully by middle of next week, we'll have actually 3 vaccines that have have emergency use authorization. And by the way, at some point in the next few months, the FDA will also then fully license these various vaccines. They just have not done that yet. To give you a sense of how a messenger RNA vaccine works, up in the upper left there, you see that spike thing that's the coronavirus, a little spiky program. It's a protein on the virus. And, you know, scientists create artificially a little piece of messenger RNA, which is then put into a little fat globule. And then they put that into a vaccine and they inject that in your arm. So they just put it in this, you know, mRNA in fat, in a syringe, injected into your arm. And then that your body recognizes that it's a blueprint. It uses that blueprint to make these little spike proteins, the little spike things on the top of the virus. Your body recognizes those spike proteins as foreign to you. And then it creates antibodies to destroy it. And it stimulates cells in your body to also help the antibodies destroy the virus. So when that full virus enters your body, it recognizes those spikes on top of the virus as foreign. So it's just remote that this genetic material does get destroyed very quickly by your body once it does its work, once it copies the spike protein and it makes these spike proteins. That material is rapidly destroyed. It does not go into your DNA. It does not go into the nucleus of your cells. It doesn't impact your genetic makeup. It can't make you sterile. It can't give you the virus. It can't do any of those things because it's not a live particle. It's not real virus. It's only a piece of the genetic structure of the virus. So it obviously can't give you COVID-19. We now have over 68 million people in the United States that have had at least one shot, and 46 million who've had one, and 21 million who've had 2 shots, and no significant safety concerns have been seen other than some allergic reactions, but not more than you would have with any other vaccine of this type. And to date, the big side effects are sore shoulder, fever, headache, muscle aches, fatigue. These are all things that happen when the vaccine is activating your system. So when you have these symptoms, these are signs and symptoms that the vaccine is activating your body's system to protect you from the whole virus if it ever infects you. Again, just to point out again that it was cut, bureaucracy was cut, because I always get asked how we can do this so quickly. Basically, we've been trying to look at mRNA vaccines for over 20 years. So what happened was just the fortunateness of having this infection, some science that people have been working on for a long time. They put it together and they're able to do it very, very quickly because they had focus, and they also got money. And, you know, they didn't have to deal with a lot of the funding issues that are involved in making vaccines. Vaccines don't make companies a lot of money. So they're very reluctant to get into this business unless they have a guaranteed customer. Also, all the states are following, in general, initially this FDA guidance. FDA said that we should prioritize first healthcare personnel because they were most at risk because they were taking care of patients, and then residents of long-term care facilities. I think most states have done that to some degree. And then they're now supposed to be working to non-essential healthcare workers, and then eventually people age 65 and older with chronic diseases. Many states are altering those priorities for a variety of reasons. You'll hear from some of the state health officers who can talk to you a little bit about what they're doing in their states as well. The challenge we've had, of course, is that we just don't have enough vaccine, and it's created some real challenges in terms of these priorities and trying to maintain these priorities in a reasonable way. The Biden administration started with a goal of a million vaccinations a day. They've increased it to 1.5 million vaccinations a day. I can tell you that the 7-day average today is that they've exceeded that already, that we're already at 1.7 million vaccinations a day. And I think to get to full-time herd or community immunity, we're going to need to get at least 3 million vaccinations a day to actually make that by midsummer. We've used the Defense Production Act to deal with some of the problems that companies were having producing the vaccine, a lot of them around raw materials. And also some of the companies have retooled the processing and the quality assurance processes that they had in order to speed up the production of vaccines. There are many people that are enhancing their vaccination options so that they are 24/7. They're trying to enhance the automated appointment systems. Many of you know that these appointment systems have really been a big problem. And we can talk about that. They're looking at ways to reduce vaccine wastage. We really don't want to have vaccine wasted at all. And the Biden administration has increased the vaccine purchases or the commitments to purchase more vaccine. So we'll have much more vaccine over the next several months. There's also been a scaling up of a government-wide response so that bringing all parts of the government involved, the National Guard and the military, FEMA, community-based groups, increasing the workforce by more quickly deploying the Commission Corps of the Public Health Service, and trying to move some bureaucratic barriers to using volunteers, at least at the federal level. There's still some barriers at the local level that still need to be addressed. In case, for example, there are places where pharmacists can't vaccinate. There are places, obviously, where veterinarians may not be able to vaccinate humans. There may be places where EMTs and paramedics can't vaccinate because they're not authorized to do so. And people are working to try to remove those barriers because all these people are quite competent to be able to vaccinate people. Also, people who are not licensed who may be retirees. And they're not licensed only because they're not retirees. People are looking to see how to bring those people back into service. Issues around the supplier line remain a big issue because it's not just the vaccine, it's stoppers, it's vials, it's alcohol swabs, it's gloves. All those things they're trying to enhance as part of the process. We do have big issues with vaccine acceptance. About 40% of the population has said that they're not opposed to getting vaccination per se, but they're not sure they want to get vaccinated. This is a study done by the Reagan-Udall Foundation, which looked at essential workers, healthcare workers, and particularly looking at people of communities of color, people where English was not their first language, and looked at Native populations. And what we found were there lots of concerns around the development and speed of the vaccine, distrust of government and healthcare systems. At least last year, a lot of concerns about the politics and economics of this issue, whether or not the programs would include enough people of color in those programs. And then these historical wrongs with like Tuskegee, and people frankly said, I don't want to be a guinea pig. A lot of misinformation and disinformation, classic anti-vaccine advocates who are pushing people not getting vaccines and using this as an opportunity to make their case about all vaccines. Data has continued to be a major problem in getting clear efforts about who's actually being vaccinated. Some of that has got to do with the public health infrastructure, the fact that we're still collecting a lot of this information on paper and sharing it through fax machines. This is a article from where I was quoted in a Seattle newspaper where we talked a bit about the fact that one of the hospitals had been very aggressive in certainly vaccinating people, but most of the information went to their medical staff, their food service staff, their maintenance staff, some of the lower income workers and support staff, food service workers. They were not in the hospital email system. They don't go to medical staff meetings, so they didn't get all the information they needed about getting vaccinated. And quite frankly, a lot of them were much more hesitant. Their degree of hesitancy was more representative of the community than the other medical concerns that healthcare providers who physicians and nurses had. And so we talk a lot about trying to ensure equity and access by making sure that vaccination sites are in the community, that we communicate to folks in a culturally competent way so that people actually understand what's going on. Just want to make you aware of a new campaign that we just rolled out yesterday with the Ad Council and a group called the COVID Collaborative. My group is a part of the COVID Collaborative. It's an ad campaign initially targeting communities of color. It's right now in English and Spanish. There will eventually be it will be in 7 different languages. But we did a lot of research, and the goal is to try to get people to move from being vaccine curious to vaccine confident to actually get the vaccine. And then my final slide is just to remind us that even though we get vaccinated, that this is part of a series of protections. Masking, hand washing, physical distancing, avoiding crowds are still a very, very important part of protecting communities. We still need to have a robust testing and contact tracing program in place, particularly now that the disease prevalence is reducing now, that we can actually get our hands around testing and contact tracing programs. And vaccination is just the end game in getting this disease under control. So with that, I'll thank you, and I'm happy to take questions.
Okay, so we have plenty of time for questions. We will start with Stella, and with the speakers today. Give them your name and tell them what your news organization is.
Hey, I'm Stella with the Tennessean. I'm based in Nashville, Tennessee. Thanks for the quick slides. It's actually very important in absolutely all the states, but in Tennessee, we've seen a flurry of bills that have been introduced to basically prohibit governments from mandating vaccination. And so I was tuning into a pretty interesting debate between a physician lawmaker and the bill sponsor, both of them Republicans. And the sponsor is basically just uttering misinformation. There is evidence that it's going to change DNA, and it's not gone through a full approval process. I was wondering, what kind of tips would you have in terms of covering these bills? Because these bills are not introduced in Tennessee. They are all over the state. All across the country. We're seeing lawmakers pushing for anti-mandate, and their argument is always individual freedom. You can't tread on my rights. So I was wondering, from the scientific standpoint, what would be an effective way for us to cover this issue, and what would be some of the things that we should keep in mind always?
Well, yeah, I just remind you that public health laws have been tested in Supreme Court over many years, and this concept of every state has these debates every year, as you know, around mandating vaccines and not mandating vaccines, and they always kind of come up with the childhood vaccines. So first thing, obviously, is deal with the misinformation and making sure that you have the facts and make sure that you know where things are not correct as part of the argument that various lawmakers are making. The debate between individual freedom and collective freedom, obviously I'm a public health person. I do believe that public health laws are put in place from a policy perspective to protect the nation as a whole and protect communities. I think there is legitimacy to the fact that this vaccine is still under emergency use authorization, and it's not fully licensed. That's an absolute legitimate argument. And I would not recommend it being at this point being mandated by anybody. First of all, the problem with mandating is that you do create that kind of resistance that you're seeing. And I think until you have a vaccine that has been around for a while and we know what we're actually doing, that we probably ought not be telling people to get vaccinated. In fact, our ad campaign is trying to give people the facts so that they will voluntarily vaccinate. So you do have to change hearts and minds. I also think it's premature for legislators, for sure, to be putting in place rules to stop people. But I think that's part of the whole anti-government issue, the same challenge we had with masks and closing things. I think it's all part of that same mindset. And again, but I think staying to the facts and pointing out where there's misinformation, but again, recognizing that there is legitimacy to the fact that the product isn't fully licensed yet. That help you?
Yeah, sir, one quick follow-up. I was wondering if you could explain more in detail about the difference between a fully licensed vaccine versus a vaccine that has gone through the EUA process.
Sure. So the EUA, they've done a full study. They've obviously looked at the risk-benefit profiles and it's gone through the administrative processes. But the company has to give more data. They have to give more data over time. They have to give more risk data over time. And there's a whole lot of paperwork that has to be filled out about the vaccine. And it just takes time to do. And before the FDA will finally approve a product for full licensure, they just have to go through all that bureaucracy. And that can take months to get done. And for example, there are a bunch of questions that the FDA would like to know, like, in addition to protecting you from severe disease, does the vaccine also protect you from sharing from transmitting the virus, as an example? Because when they license a vaccine, they're licensing it for a variety of populations. And if you're a pharmaceutical company, you want to get the fullest utilization of the product you've produced. So you want to know whether or not it can be used on children. You want to know whether or not it can be used in pregnant women, because the process to go back and redo that all over again is a big deal. So when the FDA says, yes, it's fully licensed, that you want them to be able to say it can be used for, most of these age groups, and what it does for pregnant women, what are the pros and cons on it. It's just a lot more detail in terms of what you've proven around safety and efficacy than we've done today. That help?
Okay, so we have lots of questions in line. Let me just tick off who we have, and we have 15 to 18 minutes or so. So maybe try to keep the questions to one question, maybe a quick follow-up, so we can get everybody in. We have Stacy, Stephen C., Laura, Jill, Lauren, James, Sam, and Coyote. And we will go to Stacy next.
Hey, thank you. My name is Stacy Barchinger. I'm a reporter with the Bergen Record and the Gannett newspapers in New Jersey. My question is, there is a large percentage of people in New Jersey who have gotten the vaccine that the state just doesn't know what race they are. And that's basically because between public and private vaccination sites, there's not a uniform question, or they're just not asking what race people are. And given the disparate impact of the vaccine or the virus, we know how important this is. So I'm wondering if you would recommend a way to, or is there a best practice to better know that the vaccination is getting to communities that are impacted by the virus?
So, the CDC does want that data, and quite recently, the Resolve the Same Lives, which is the organization in New York that Tom Frieden runs, who's former CDC director, and our organization released a data set that we think should be a uniform data set collected by all states. And so I would just commend you to take a look at the Resolve to Save Lives website. We also said that you ought to collect the data by race and ethnicity as part of that. The challenge you have is that, that you're right, the data is often not collected. Every state is collecting data sets differently. The CDC wants them collected by race and ethnicity. As you can imagine, there are some people who, for whatever reason, don't want to tell you what their race and ethnicity is. But we really need that. And the challenge we've had since the beginning of this outbreak is the collection of data. And a lot of it's collected by hand in many places. It may or may not go into an automated system right away. You have people transcribing the information along the way. Sometimes they do it incompletely. Even though the boxes are there, even though the forms say it, it may very well not, get filled out for a variety of reasons. And that's a problem. And why it's a problem because it doesn't let you, once you don't know what's happening, you make assumptions that groups are or are not getting vaccinated, and you can't target your vaccinations, as you pointed out. And this has been a problem for many public health programs, so it's not a new problem. And they just need to fix it. The public health data systems are antiquated, for anything. And you would think that after all these years, we would have a immunization registry system that's national that forces you to put the data in. You can't go to the next screen until you fill the boxes out. Even if you say patient doesn't want to answer, okay, at least we'll know what that means.
All right. Next.
And it was Resolve to Save Lives is the name of the company.
All right. Next up, we have Stephen C.
Hi, Dr. Benjamin. Whoop, sorry about that. I was just sort of curious about when it comes to vaccine skepticism, are there any organizations that you think do really good work in terms of I guess not just ad campaigns, but grassroots efforts, or what are best practices for breaking through vaccine skepticism?
Oh, absolutely. So the first thing is you really need to is both the message and the messenger. And there are several groups that, there are many groups that are working on this. Groups from the COVID Collaborative have put out issues. The DeBeaumont Foundation in Maryland, it's in Bethesda, Maryland. Frank Lutz, who's a Republican pollster, put out a very important survey looking at words that you should use. So some of the things you should do are, again, don't make assumptions about what people know. Ask them what their concerns are, then address their concerns specifically. Talk about the science, talk about public health people. Talk about the people behind the vaccines, not the drug companies. People don't like drug companies. Talk about the fact that the vaccine, how the vaccine could be produced in record time. Talk about it, how the science came together so that you can address people's concerns. Because at the end of the day, it's about safety and it's about efficacy. Talk to them about how effective the vaccine is. Use messengers of people they trust. I like to think people trust me. Probably not. But if I can convince some people who people trust, pick your favorite basketball star or movie star or your pastor, Mrs. Jones down the street, who everybody trusts. Everybody has a Mrs. Jones in their community. Giving those people the knowledge base so that they can be verifiers, barbers and beauticians. So there's a group out in the dean of the School of Public Health in Tulane University, Tom Leviste. They have a program working in the community to use trusted messengers and engaging community workers to address these communities dealing with the misinformation. In Los Angeles, there's a group called Cure Violence. Cure Violence are violence interruptions. They're mostly funded through Attorney General's office and criminal justice groups, and they go into communities to try to interrupt violence from gangs. Well, they have pivoted to educating around COVID because they're trusted in the community. They can go places where other people can't go and talk to people and get people to listen to them. Healthcare for the homeless, which is reaching into its homeless population to try to address communities effectively. So many of the state and local health departments have groups that are doing this as well. So those are the kinds of groups that I think that one should think about. But I do plead this ad campaign is going to be more, it's going to be TV, radio. It's going to involve influencers. TD Jakes, I guess, is involved in the campaign. I know Reverend Sharpton and his group are actually involved in this effort. So there's a range of people around the country that folks trust that are beginning to speak out on these issues. And part of at least the campaign we're doing right now is in English and Spanish.
All right, so we have Laura is next. And Dr. Benjamin, if you can kind of maybe think in terms of shift to CNN mode, 60-second answer, so we can try to get through six or seven more questions here before the end. So Laura.
Yes, Doctor, thanks for doing this. I'm Laura Bischoff. I work for the Dayton Daily News in the State House in Columbus, Ohio. I was wondering, this kind of piggybacks off of Stella's question about bills and state legislatures. In Ohio, there's several bills that would seek to kind of dilute the power of public health orders and give more legislative oversight rather than having the governor and the health director to just issue orders quickly. Can you talk a little bit about what the risks are of these kinds of bills? What's the upside or downside to it?
Yeah, people will die. The reason your police department has police powers is for them to be able to act without having to act in committee. The reason public health people have police powers are the same reason.
That was very CNN mode.
It's true.
Okay. All right. So we'll go to Jill.
I have two questions, but if we can only answer one, that's fine. First, I was wondering if you knew what temperature the Johnson & Johnson vaccine has to be refrigerated at, because a lot of the issues we saw here in Texas and rural communities is that they didn't have refrigeration capacity for, I think, the Pfizer one was the first one that was approved, Pfizer, and then Moderna came online like 2 weeks later. So I'm just wondering if that's going to be an issue with the Johnson & Johnson vaccine.
It's not an issue. It can be kept in a regular refrigerator, and I believe it can be kept frozen for about a week.
Okay. And then the other one I was going to ask, because I guess I'm just kind of confused about why some states are making public school teachers essential, and they're moving them up in line to get vaccinated, and other states aren't, like Texas is not. And that's been a big issue here with among the public education community.
Politics, strength of your lobby. Although I think if you're going to get the schools back in order, you got to get the teachers vaccinated.
Okay, that's kind of the answer I was looking for. All right, thank you.
Okay, Lauren.
Hi, thanks again for this presentation. I'm Lauren Gibbons, and I'm the State House reporter for MLive, which covers the Grand Rapids Press, Ann Arbor News, and several other papers in Michigan. My question is specific to a movement that came up this week in Michigan regarding the social vulnerability index. There are a number of Republicans now who are trying to strip the social vulnerability index from vaccine distribution and exclusively go based on the number of seniors in a community, basically stripping race and other factors from it. They're trying to tie that to the federal COVID-19 funding that Michigan is getting. And I'm wondering, one, if you're seeing that trend in other states or other Republicans trying to, focus this on seniors. And I'm also wondering, because this is a relatively new concept to me, if removing the social vulnerability index from vaccine distribution would harm communities that have been hardest hit by the pandemic.
Yeah, this is a misunderstanding of what that does. Of course, it's done to get through social vulnerability, but they see it as race driven. Quite frankly, from my view, it's a racist concept to try to remove it, because they perceive that people of color are going to be disproportionately advantaged. The truth of the matter is, if you're in Appalachia, that community is disproportionately impacted and would benefit from social vulnerability assessments. If you're low income white in rural Texas or rural Oklahoma, you're going to be helped by that evaluation. So I think they really don't understand what they're doing. And there's somehow this perception that somehow it's going to advantage one group over another is a terrible, terrible mistake.
All right, so I'm going to push this 5 extra minutes. We're still not to get to everybody, but if you don't get your question this round, our next session is all Q&A, and I'll make sure you'll be at the top of the priority list. But right now, let's go to Coyote.
Must be muted.
Thank you for this presentation. My name is Coyote Crown. I work with Jackson Free Press in Jackson, Mississippi. Please, what is the difference in the platforms for Johnson & Johnson, Moderna, and Pfizer? You mentioned one of them, mRNA. Talk about the others, please.
Sure. Both the Moderna and Pfizer vaccines are both mRNA vaccines. They use the mRNA platform. What that means is they make a little piece of mRNA in the lab, they put it in a fat bubble, and then they inject that in your arm. What the Johnson & Johnson does is it takes a virus, an adenovirus, which cannot make you sick, and they put in that virus a little piece of the DNA for the SARS-CoV-2 virus that causes COVID. And then that DNA goes into your body, put in the vaccine, injected in you. It then makes the mRNA and does exactly the same thing from a biological process. And so what the mRNA platforms do is they cut out the middleman being the RNA, the adenovirus. So it's just a different way of delivering it into your body.
Next, we have James.
This is James Barragan. I'm with the Dallas Morning News in Austin. And my question is, what is the most equitable way for states to distribute vaccines among counties? Are there specific factors that they should consider?
Well, the people are doing the easiest way is trying to do it, by population size. I mean, if you could sit down and you had enough vaccine and you could, cut up an algorithm that could look at the vulnerability, look at age. I mean, you could put a whole bunch of factors in there. And the truth of the matter is that the most ethical way is to try to focus on people who are the most vulnerable first. Once we did the healthcare workers, we did that for a bunch of strategic reasons. We did long-term care workers first because they were people the most likely to die. And then most people are now looking at it by age. So a lot of groups are looking at it by age because they're perceiving them to be more vulnerable than others. But the answer is, beyond vulnerability and how you define that, there's really no right way.
Thank you.
Okay, I'm going to try to cram in 3, maybe 4 questions. We'll go to Sam.
Hi, I'm Sam Metz from the AP in Nevada. You talked a little about appointment systems being a big problem. We've definitely heard that too. I'm wondering why this is a problem that frustrates public health officials so much and why it's been so hard to fix.
Money.
Need the better tech.
We need money and better tech. Like I said, we're still sending information around by fax machines. Nobody does that anymore. After 9/11, a lot of money was poured into public health.
Hello, my name is Stefan Johnson. I am a staff writer for the New York Amsterdam News. My question involves simply the rollout process. Do you think there should be a uniform rollout process, considering that each state has its own and it's kind of discombobulated? I know, for example, here, where they have the drug chain stores involved in distributing a vaccine, and you have to go to the website, fill the stuff out. And from personal experience, even if you put in that you have a pre-existing condition, which they ask for, and you give them the specifics of that pre-existing condition, they'll still tell you you're not qualified to get the vaccine. So what can be done to ensure that there's a uniform process?
You know, once the Trump administration decided that they were going to make that state-based, we were on that glide path, and I don't think you can change that meaningfully without disrupting the whole thing. I think what the federal government can do is put out broad guidelines and support each state in trying to do what they want to do very quickly. They can, create better automated systems. They can give them more money. But I think if we can get enough vaccine in the states, we can get everybody vaccinated. I know it's frustrating, but at the end of the day, most of what you're saying is the end problem of not having enough vaccine.
Okay. So we'll take a question from Tiffany, and then we do need to let Dr. Benjamin go, and then we'll take just a brief 5-minute break before the next panel starts. I apologize, we didn't get everybody's question in. But Tiffany, you have a last shot here.
Hi, I'm Tiffany Stecker, and I'm a reporter for Bloomberg Law in Sacramento. My question is more on the variants and how infectious they are. How do individuals take that information? How much of a risk is it to individuals, and how should they, alter their behavior? Do they need to stand 10 feet apart rather than 6 feet, double masking? How does an individual sort of?
Yeah, short answer is we have no idea yet. But we do know that there's a series of layer protections that if you wear a mask, I'll come back to the double mask in a moment. Wearing a mask, washing your hands, keeping your distance. I think 6 feet is still a reasonable period. Not getting in large crowds and getting vaccinated when you're eligible will reduce your risk. Because at the end of the day, it's all about reducing risk. I would much rather people wear one mask well than two masks incorrectly. And the purpose of that mask, it has to be tight. So if the mask is tight and 2 or 3 ply, then you're probably fine. The virus doesn't have wings. It doesn't have more legs. It's when you say it's more infectious, it means it's more sticky. It means that once it gets into your airway, it holds on tighter and has a better ability to get into your lungs. So anything you can do to keep it from getting into your airway will reduce transmission fundamentally. That's the simplest answer. And I think this happens all the time. Remind you that the flu mutates all the time. That's why you get a new flu shot every year. And the more likely future we have, I don't know this for sure, but the very likelihood that was having to take a vaccine with some periodicity, that's an updated vaccine, whether it's a year or 2 years or 3 years, is most likely the future we're going to have, unless all of a sudden, suddenly this thing goes away.